Hello, good afternoon, everyone. Good afternoon, ma'am.
Hello, good afternoon. Good afternoon, everyone.
Shall we start, ma'am?
Yeah, all ready to start.
So, a very good afternoon to one and all present here. I am Monica Singh, the 54th student of the Chandiwala Institute of Physiotherapy. With a very warm welcome to you all in today's webinar on the topic Parkinsonism. Am I clear, ma'am?
Yeah.
Okay. So without any further delay, let's begin our today's session by welcoming our eminent speaker, Dr. Astha Jain, Senior Pediatric Physiotherapist at Birmingham Community Healthcare, England, United Kingdom. Ma'am has done her Master's in Physiotherapy in Neurology from College of Physiotherapy, SST Hospital, Vadodara, Gujarat. She is a gold medalist and won many quiz competitions such as NCEP, AIMS, and Physiofista. She also won first prize in paper presentation on topic impact of static versus dynamic start on results of 10-meter walk test in patients with acute traumatic brain injury at Physio Summit, a global physiotherapy apex in 2014. Talking about her publications and achievements, ma'am had published several research papers on article Motor Imaginary in Physical Therapist Practice, published in Physiospace November 2014, Impact of Static versus Dynamic Start on Results of 10-meter walk test in patients with acute traumatic brain injury, Volume 10, Number 1, January-March 2016, published a paper titled Effectiveness of Three Different Surfaces for Balance Training on Ambulance Stroke Patients, a Comparative Study, in IJSR Volume 6, Issue 10, October 2017, published a paper titled Multimodal Rehabilitation in Ataxia, a Case Report in International Journal of Scientific Research, Volume 8, Issue 7, July 2019. About her work experiences, ma'am was an assistant professor and then visiting lecturer at Amar Jyoti Institute of Physiotherapy and now senior pediatric physiotherapist at Birmingham Community Healthcare. She is also yoga certified from Yoga Niketan, Baroda. Welcome, ma'am. Now, I would request ma'am to kindly take over the session and enlighten us all. Welcome, ma'am.
Thank you so much. Thank you for such a warm welcome. A very good morning. Sorry, a very good afternoon to one and all present there. And shall we start already? Shall I share my screen?
Ma'am, you can share now.
Thank you. Is my screen visible?
Yes, ma'am, visible.
Okay. Good afternoon again, one and everyone present here for an interesting discussion about some highlighting aspects related to the Parkinson's disease. A very great thank you to Banarsidas Chandiwala Institute of Physiotherapy, BCIP, and the staff members of BCIP for inviting me, for sharing this platform and given an opportunity to discuss about the highlights relating to Parkinson's disease and its impact on the physiotherapy practice, or how the physiotherapy practice is important in patients with Parkinson's disease. So here we are all just about to discuss regarding some highlights related to Parkinson's disease. Maybe clinically, we all are aware about the aspects of Parkinson's disease, as you can see in the background of the slide, that Parkinson's disease immediately strikes us with some cardinal features of Parkinson's disease like rigidity, tremors, bradykinesia, and postural instability. But that, am I audible properly, or do you want me to make some changes? Just to check. Hello.
You're
Yes,
audible,
ma'am.
ma'am.
Yes, ma'am.
Okay. Thank you. So as I was mentioning that immediately as soon as we discuss about the Parkinson's disease, we come to an idea about so many cardinal features about the Parkinson's disease. But Parkinson's disease has now widened to a lot. Parkinson's disease is not only about the motor symptoms or not only about the cardinal features. Today, the definition of Parkinson's disease has been broadened to a lot extent, which includes so many other dimensions or so many other aspects which needs to be taken into consideration when dealing with a patient with Parkinson's disease, or when looking to a patient with Parkinson's disease, or planning a protocol for a patient with Parkinson's disease. Let's go and have an insight into same. So Parkinson's disease, as all of us know, is a progressive neurological condition characterized by motor and non-motor problems. The main changes arises from the brain dysfunction through the reduced production of a chemical messenger or a neurotransmitter, that is dopamine. This is the main pathophysiological basis behind the occurrence of Parkinson's disease, that is reduced production of the neurotransmitter dopamine, affecting the extrapyramidal system of the brain, leading to a progressive neurological conditions where there are several motor and non-motor problems. And that is what is the Parkinson's disease. However, the Parkinson's disease has certain cardinal features, and when any of this large number of clinical syndrome is present due to any reason or any type of dysfunction within the brain, then it is referred to as a clinical syndrome known as Parkinsonism. However, there is no difference in the aspect of the clinical care that we provide to any patient having any type of this umbrella symptoms. The most important thing which we need to consider whenever taking care of this patient with Parkinson's is to look about the type of the motor and the non-motor symptoms present. The most important impact is the type of the motor and non-motor symptoms present in a patient with Parkinson's. No two patients are same, or the clinical presentation of no two patient is similar. Every patient or each and every patient of Parkinson's disease has a different presentation. As such, we have seen that some patients are tremor dominant, some patients are rigidity dominant. However, to the most surprising thing that you will come to know is some patients are non-motor symptoms dominant. That is, the patient do not have the cardinal symptoms of rigidity, tremors, or bradykinesia as their main presenting feature, but they are presenting with other non-motor symptoms due to Parkinson's disease, and that is the classical different type of presentation. So the most important thing, whatever presentation the patient with Parkinson's has, whatever severity the patient has, the most important is to consider each and every patient individually and a custom made tailored approach for each and every individual patient. Parkinson is the second most common neurodegenerative disorder. According to the recent literature, it suggests that the prevalence of Parkinson's disease is increasing day by day. And it is estimated that by 2040, that is coming 19 years, the estimated rise of the population of Parkinson's will be around 12 million, and which will make the Parkinson's as the fastest growing neurodegenerative condition. I hope that is a very alarming sign for each and every healthcare professional. When Parkinson has been labeled as the fastest growing neurodegenerative condition, that means it's a really big impact on the healthcare profession, or it is a very important thing which needs to be considered in designing the care of patient with Parkinson's. Historically, as what this I have discussed a bit in my previous slide, that historically it was said that Parkinson is a motor condition with a diagnosis based on the cardinal motor symptoms of tremors, bradykinesia, rigidity, and postural instability. However, I will again like to highlight that Parkinson is now no more a only motor condition. It is a broad condition with more than 40 symptoms, including non-motor symptoms, which can predate the classical motor symptoms by up to between 5 to 10 years. So for an example, to elaborate that, I will explain that maybe sometime we see a patient who is having non-motor symptoms for up to 5 to 10 years before the patient presents with a single cardinal feature of tremor, bradykinesia, or rigidity. So that's what I'm trying to highlight, that it is not always necessary that the patient has tremors, bradykinesia, rigidity, or postural instability. That is not the only criteria to label a patient with Parkinson's disease. It has become a very broader term, and several non-motor symptoms are now preceding the motor symptoms as well. As we have already discussed, that the prevalence is increasing day by day, and it has become one of the most commonest neurodegenerative disorder, and is having a wide variety of clinical presentation. There is a lot difference in the presentation from patient to patient. So non-motor symptoms, as I mentioned, that Parkinson's has motor as well as non-motor symptoms. Some of the non-motor symptoms which are commonly seen in patients with Parkinson's are depression, anxiety, fatigue, cognitive impairments, apathy, which are increasing the burden on Parkinson's patients. If we discuss, the patient already has the motor symptoms, and in addition to that, the patient has non-motor symptoms, or sometimes the patient first has a non-motor symptoms and then going to motor symptoms. So this is causing a vicious cycle where the person is suffering with the movement dysfunction, postural instability, apathy, and a constant vicious cycle of reduced physical performance, reduced emotional stability, reduced cognitive functioning of the patient, anxiety, fatigue, and depression. So it is affecting the physical, emotional, and psychosocial aspect of an individual health. The most recent approach which is used in the healthcare, that is, it is affecting mind, body, and psyche, all the aspects of an individual health. It's not only a physical condition, it's not only an emotional condition, it's not only a cognitive aspect. Parkinson's is a complete package of everything where a person suffers from the physical, emotional, cognitive, and all the aspect or all the dimensions of life. This in turn is instigating a fear of movement, a fear of fall, and ultimately contributing to social isolation and reduced participation in day-to-day life, or reduced participation in the activity. This is how the vicious cycle of Parkinson's keep on continuing and is constantly increasing the burden over the aging population. As we already discussed, that the population aging is increasing, there are increased incidence of Parkinson's, and there is an increased vicious cycle which is precipitating to reduced effectiveness of the elderly community. Gait dysfunction, a typical gait which is seen in the Parkinson's disease, that is a short, shuffling, fascinating gait pattern with stop and start hesitation, initiation failure, or we can call it as a freezing of gait, difficulty in changing directions, difficulty in turning, difficulty in accelerating or decelerating, or start and stop abruption is also a very important challenging aspect. Owing to the progressive nature and the symptom diversity, the management of Parkinson's disease is really very complex, and no cure currently exists, and the symptomatic management is reliant upon medication which targets dopamine imbalance through a variety of different mechanisms. The main medical treatment which is currently in practice is mainly targeting dopamine precursors. Various different dopamine precursors are given to the patient with Parkinson's disease over a period of time. However, it is very, very clearly evident based on the literature that each of the drug over a period of time get adapted to an individual's body and requires an adjustment in the dosages, requires an increase in the amount of the dose required, or the on and off period of that particular drug, which means to say that whenever a medication is given to a patient with Parkinson's disease, that is any dopamine precursor is given to the patient with Parkinson's disease, is going to create an effect only for certain number of hours, that is known as on period of patient. And after the effect of that particular drug declines, again the patient gets very severe with its motor and non-motor symptoms, that is known as off period of that particular medicine. So this is a very important challenging aspect which is generally seen in patients with Parkinson's disease, that the on and off period of the medication or the on and off period of the drug sorry, is constantly requiring the adjustment of the drug dosages. Although medications is beneficial, it is serving only in the reduction of the impact of the symptoms. However, it is not at all addressing the pathological progression of the disease. I mean to justify my statement here that whatever medicines are given for the patient of Parkinson's disease is definitely helping the patient to control the symptom, but it is not affecting the pathological neurodegeneration that is acting within the brain, or whatever pathological changes are occurring within the brain are not halted with that particular thing, or they are not reversed with that particular thing. So whatever medication is given to a patient with Parkinson's disease is just managing the symptoms or the presenting symptoms of a patient with Parkinson's disease. So based on the platform that we have built up right now, or whatever insights we had into the condition of Parkinson's disease, we looked upon what is the presentation of a Parkinson's disease and how fast it is growing in this aging population. Life expectancy is increasing day by day due to medical advances, and the burden of increasing neurodegenerative disease is a real challenge for the medical fraternity all across the globe. Hence, it is need to define the best practice in Parkinson's disease, or what is the best approach in Parkinson's patient. The complexity and the diversity of Parkinson's disease necessitates a team-based approach. A team-based approach, which means to say that combining the experience of patient and input of several healthcare professionals, that is only a key to success to provide the best practice in a patient with Parkinson's disease. So let's see how we as a physiotherapist can play a role in this healthcare professional group. As we just discussed in the previous slide, that all of the healthcares or a team approach is the most important essential criteria to work with a patient with Parkinson's disease. Let's go to our domain of physiotherapy practice, or as an exercise therapist, what can we do in a patient with Parkinson's disease? Or what is the scope of exercise therapy, or what is the scope of physiotherapy in this ever devastating increasing neurodegenerative disorder of Parkinson's? So exercise is regarded as a new medicine for Parkinson's, and it positively impacts both motor and non-motor symptoms. I think it should be a very big reward for the entire physiotherapy fraternity. International literature says that exercise is a new medicine for Parkinson's disease, which means that the physiotherapy fraternity or the community has a lot to do and a lot more to do for patients with Parkinson's disease. We have a significant role to play in patients with Parkinson's disease because exercise is regarded as a very important factor helping the recovery or helping the maintenance of patient with Parkinson's. Systematic reviews, there are n number of systematic reviews or literature which supports that the exercise are associated with improvement in strength, gait, balance, function, cognition, and lot of other outcome measures. Emerging research is also suggesting that the high intensity exercises induces a neurophysiological change within the brain, promoting a neuronal health and declining the rate of Parkinson's progression. Again, to elaborate my the statement, this means to say that there is also a recent literature which says that exercise is not only helping in improvement of symptoms, but it is also showing an effectiveness where there is a slow progression of the changes, or where the deterioration of the neuronal structures within the brain has also slowed down with the help of the effect. This is a very positive feedback for us that how the exercise is affecting the Parkinson's patient. So most importantly, I will like to discuss two important dimensions which are very important for a physiotherapist to work in patient with the Parkinson's disease. As we know, every assessment is a treatment and every treatment is an assessment. Two important aspects of physiotherapy, that is assessment and treatment, or assessment and management, cannot be separated from one another. Each and every patient or each and every individual where you are providing your physiotherapy input or where we are targeting our physiotherapy input, it is most important precursor step for us to have a complete physiotherapy assessment for that particular patient, to have the exact idea of the current functional status or the current symptom severity for the patient. If we don't have an exact idea of the current status of the patient or exact severity status of the patient, or what are the factors which can confound my therapy protocol, it is impractical to start a management program. So always we instigate that, or always I request each and everyone that to have a complete thorough assessment of the patient, which will give you a guideline regarding the current level of your patient before going for the management protocol. Also, each and every individual has a different skills of assessment or different set of criterias. So apart from the standard neurological assessment, we always do a standard neuro assessment for each and every patient with neurological conditions. Maybe I think motor assessment, sensory assessment, gait assessment, balanced assessment, higher motor functions, cognitive assessment, perception, cranial nerve, what all. Apart from the standard set of assessment that we follow in a neuro patient, I recommend that there are certain symptom specific assessment which needs to be incorporated into the assessment of each and every neuro condition. Like as we saw, there is a diversity of symptoms which are seen in a patient with Parkinson's disease, and I suppose in each and every neurological condition. So specific to the diversity of the symptoms, a person-centered approach is necessary for the physiotherapy assessment. So when I talk about my Parkinson's patient, it's very important to do the assessment for the rigidity, as rigidity is a very important factor which is seen in patient with Parkinson's disease. What type of rigidity is seen in my patient? That is a sustained rigidity, either lead pipe or cogwheel intermittent rigidity seen in my patient. Is there similar presentation of rigidity in both the sides of the body, that is right side and left side, or upper limb and lower limb? How is the presentation of the rigidity in my patient? Whether there is a truncal involvement as well, or only the limbs are more affected. So if I have a complete idea to what extent the rigidity or to what extent the tonal component is affected in my patient, it will be a first thing which I need to look at. Another cardinal feature seen in the Parkinson is bradykinesia. Bradykinesia, simply, we all are knowing that bradykinesia is the slowness of movement which is seen in a patient with Parkinson's disease. But I need to look into my patient, or I need to thoroughly assess my patient and see in depth that to what extent there is bradykinesia in my patient, whether the movement time is affected in my patient or reaction time is affected in my patient. Movement time says that how much time a patient takes to complete a particular task or particular movement given to patient. And reaction time is the time elapsed between the command given and start of the movement. So this can be compared over both the sides of the body as well to see the difference, or it can be noted over a period of time. That is, for example, if I'm starting the plan of care or POC for my patient from today, after a couple of weeks, I can again take the movement time and reaction time in my patient, or I can see when my patient is taking drug and during the on period of that particular drug, what is the movement and reaction time in my patient, and during off time, what is the movement and reaction time in my patient. So we can accordingly plan our physiotherapy input to coincide during the on time of the therapy to get the best out of the patient's motor components. So that is why it is very important to assess the movement time and reaction time in my patient and see the progression and changes on the both sides of the body or progression over the time. Again, one more important cardinal feature seen in Parkinson's, that is tremor. So in-depth assessment of each and every aspect of the tremor needs to be done. Like what's the location of the tremor? What's the persistence of the tremor? How severe the tremors are? What is the amplitude of tremor? What is the pattern of tremor? That's either it's a pin rolling tremor or supination pronation tremor. It's a resting tremor. Generally, we do have resting tremor in patients with Parkinson's disease. Is there any factor which is aggravating the tremors or relieving the tremors in my patient? Mostly we see the patients get aggravated with their tremors in the stressful situation or sudden temperature fluctuations. Extreme weather conditions can aggravate the tremors, or stress can aggravate the tremors. However, medicines, rest, relaxation can help in relieving the tremors. So we need to look at the aggravating and relieving factors of the tremors before we decide the protocol, how we are going to manage this particular symptom of my patient with Parkinson's disease. Postural instability. Postural instability is again a very important aspect which we see in a patient with Parkinson's. We see the posture of a patient is generally kyphotic or a stooped posture, also known as phantom pillow posture, if any one of you has heard. That is, the posture of a patient with Parkinson's disease can be graded by the pictorial gradations of the posture, or you can assess various components of the balance like retropulsion test, that is nudging the patient with your closed face over the sternum of the patient to see what is the status of the postural stability for the patient, or several other components of static and dynamic balance assessment. So you can assess the postural instability of patient in multiple ways or multiple patterns. You can assess the posture of the patient. You can assess for the gait of the patient, like we have already discussed. There is a typical gait which is seen in patient with Parkinson's disease, that is known as freezing gait or festinating gait. So we need to assess each and every demographic characteristics or dimensions of the gait, like speed of walking, stride length, step length, cadence. All the factors needs to be assessed. Apart from that, a documentation should be also done regarding if any assistive aids have been used by the patient, or what is the frequency of the freezing episode seen in the patient. If we see a patient with Parkinson's disease walking, is there any specific factor which is causing the freezing of the patient, or what is the pattern of freezing seen in my patient, like after every 10 steps my patient is freezing, or when my patient passes through a narrow space my patient is freezing, or whenever there is turning or changing the direction my patient is freezing, or my patient is able to pass well, because each and every patient will be different. No two patient will have a similar presentation. So we need to look into detail that what is the factor, frequency, or what is the triggering stimuli causing the freezing episode in my patient. What is the frequency of fall? Also, the guidelines suggested for Parkinson's assessment mention that a fall risk diary is a very good idea to be used in patient with Parkinson's disease, where you can ask your patient to maintain a 24-hour diary log roll over a couple of days or a week, and ask the patient to document each and every episode of fall and what was the reason for that particular fall. Just a random fall, or sudden stress instigated a fall, or a difficult situation of walking or narrow path or changing in the position or outdoors. So we need to maintain a fall risk diary for a patient with Parkinson's disease to see what is the frequency of fall. Dual task walking is again a very important challenge seen in the patient with Parkinson's. That is, when the person is carrying out two tasks simultaneously, it's difficult for a patient to do the best in both the tasks. That is like walkie-talkie test is a standard valid and reliable test which can be used for the assessment in patient with Parkinson's disease, which says that ask the patient to walk along with the talking and see if there is any differences in the gait or whether the patient shows a difference in the pattern of walking when the patient was just walking and now patient is talking and walking. That is, the patient is cognitively engaged in one more task, that is talking, and walking, a physical activity the person is doing. So we are combining a cognitive task along with the physical activity. So this is an example of walkie-talkie test, how we can use in the clinical practice. Autonomic functions. Autonomic functions are commonly affected in a patient with Parkinson's disease, like salivation is affected. There may be a drooling of saliva, or sweating may be there, excessive sweating, reduced sweating, orthostatic hypotension, dizziness. Sometime to my surprise, I think that why do I need to inquire about autonomic functions, or is it important for me as a physiotherapist to know about the autonomic function? Yes, it's very important for me to know. Whenever I'm planning my exercise protocol, I need to take care if my patient is having any autonomic dysfunction or any autonomic functions which are affected. I need to take care while devising my protocol that the patient should not be facing any episode of orthostatic hypotension in my care, or patient should not have an episode of excessive sweating or dizziness. So a proper paced exercises should be given. Adequate rest period should be given in between, or adequate incorporation of the breathing exercises or relaxation should be given. So this all should be depending upon the status of the autonomic functions of your patient. Cardiopulmonary status. Always the patient, or oftenly the patient with Parkinson's disease, have a flexed kyphotic posture, head carried forward generally, and this can have a wide impact on the cardiopulmonary function of a patient, chest expansion, respiratory rate, heart rate. So it is important for us to assess that any component of cardiopulmonary function is been affected for our patient. So you can go and you can add those components as well into your management program. If there are any integumentary areas or pressure areas, which are generally less common in a mobile independent patient. However, when the patient progresses to the more severe stages or the later stages, where the person is quite confined with the mobility aspect, then there are chances of development of pressure areas. We can assess functional status of patient in detail. Several measures are available, standard measures are available. For an example, functional independence measure is also reliable and valid to use in the population with Parkinson's. And it can help us to document the current functional status of the patient. And accordingly, we can get an idea of what domains of the independence are affected. Because what we are doing, or what a physiotherapist is doing, is rehabilitating the patient. So our approach needs to be patient centered. What are the concerns of the patient? What are the areas where the patient is facing problem? And accordingly, we need to develop the plan. Like just I was mentioning, depending on the stage where the patient is there, widely two different scales are there. The latest one, or most commonly used these days, is the modified Horn and Yahr scale to measure the severity of Parkinson's disease, and which is classifying the patient into different stages. The older one, Horn and Yahr scale, was just stage 1, 2, 3, 4, 5, but the newer one has added two more components in between, that is stage 1.5 and stage 2.5, making it, rather than 5 stage, to a 7 stage classification for Parkinson's disease. However, there has not been a great difference in the nomenclature. It is more or less similar, progressing from Unilateral involvement only, that is the patient is having the symptoms more on the one side of the body, then involvement of the trunk, then involvement of the bilateral, that is both the sides of the body, and then there is an involvement of the balance component of the patient. Patient is independent. In stage 4, the patient is severely disabled but still able to walk with some of the assistive aids. And stage 5, the person cannot walk independently and get confined to wheelchair or some of the mobility device to help unless the patient becomes bedridden. So these are the stages of Parkinson's disease. So it is very important, based on our assessment, we can have an idea what stage my patient is and what is my expectation or what is my goal to move my patient from this particular stage to what level of functional independence. Unless and until you have an exact idea about what is the current status of your patient or what is the current level of your patient or current functionality status of the patient, it's quite impractical and difficult to decide upon the management plan for your patient. So outcome measures, again, a very important part of your assessment procedure is to use an effective outcome measure. An outcome measure should be relevant to the patient values and perceived need, measuring the aspects of health and function that are relevant to the treatment offered. It should have a sound psychometric properties that should be a reliable, valid, quick and easy to complete, and it should provide a meaningful information. This is the most important requirement for any outcome measure. The most relevant and valid tool available today in today's date for Parkinson's disease is Unified Parkinson Disease Rating Scale, that is UPDRS. Movement Disorder Society, that is MDS, has published the UPDRS scale in multiple languages. You can scroll down the website of Movement Disorder Society. You can note it down. MDS, that is Movement Disorder Society, has published UPDRS in multiple languages. And to our surprise or to our privilege, that we also have a Hindi version available for that. So if you want to use it in any of your patient, you have multiple languages available for UPDRS and which have been published on the website. You can have a look over it. The scale is a detailed assessment of a Parkinson's patient and addressing almost all the motor and non-motor domains of a patient with Parkinson's disease. So let's go to the physiotherapy management. How are we going to manage a patient with Parkinson's disease? Till now, I have emphasized multiple times saying that a physiotherapy management cannot be same for any two patients. It needs to be devised based on the needs of your patient or based on the assessment of your patient. But some of the important aspects or some of the important strategies that we can use in a patient with Parkinson's are the motor learning strategies, a wonderful approach that can help us in neurodegenerative disorders. It is really, really very helpful by using the strategies of procedural learning, that is breaking a complex movement into the components part, giving real life environment or real life situation and practicing the components of that particular part. Always avoid dual task initially in patient with Parkinson's disease. Go with a single task. Practice the single task independently. One more single task, practice that independently, and then try to combine both the individual tasks together and make a dual task situation for the patient. That is the best approach in motor learning strategies. Always use auditory cues or visual cues, how the patient reacts best. You can try and error with the patient that what type of the things helps my patient better. Either floor markings or lights or visual flashing lights can be given. These days, so many adaptations have been made in the external environment as well. The reflective lights are being put on the streets or floors, or the visual targets can be given. Laser lights can be used. This different type of the visual cues can be used for training a patient with Parkinson's disease, or auditory cues can be used like multisensory cues, metronomes, different type of voice recording or auditory commands exactly when the patient is practicing in a real life situation. Constantly give commands based on the situation or based on the requirement of the patient. So these are some of the strategies that we can incorporate in planning of the management. That is the auditory cue, visual cues, or various learning strategies can be added. Exercise training, as we have seen so many requirement of the exercises, rather relaxation exercises, rhythmic initiation, diaphragmatic breathing, flexibility exercises, that is active range of motion or passive range of motion exercises, depending on the status of my patient, AROM exercises, strengthening of the weak elongated extensor muscles, that is the back muscles, and lengthening of the short flexor muscle, that is the anterior compartment or the anterior side is generally shortened because of the posture, and the posterior side is lengthened and weakened because of the presentation of the patient. PROM exercises like PNF patterns of D2 flexion can be used to counteract the effect of kyphosis. These are some of the examples. You can use multiple examples like chop reverse chop pattern of the PNF can be used. D2 physiological flexion pattern can be used. So based on the presentation of your patient or what component of the shoulder, elbow or trunk or what are the limitations, accordingly you can use multiple combinations or of active or passive range of exercises. Functional training. A lot of functional training can be provided in patient with Parkinson's disease, depending on the goals devised by the therapist and the patient. Functional training has to address the real life situation for the patient. If at all something is made interesting for the patient based on the real life situation, it's always easy for the patient to practice that particular activity rather than just practicing 10 repetitions of flexion, like 10 repetitions of shoulder flexion and modifying it with an interesting task where a person, for example, is lifting up a ball, taking it to height and throwing. Practicing somewhat in a functional situation or interesting situation always makes it easier for the patient to perform that. Lot of functional aspect has been current date covered by occupational therapy practice as well, like modification of the clothes, loose fitting clothes, velcros on the clothes, modification in the shoes, cutlery, heavy weighted cutlery for prevention of tremors, or modification made in the stationery and cutlery, modification in the clothes. However, these aspects are more addressed with the occupational therapy, but always as a physiotherapist, you can liaise with an occupational therapist, or you can be a chief component into a multidisciplinary team for advising regarding your patient. Balance training and locomotor training. Balance training is important, which can be provided by weight shifting exercises, reaching exercises, reaching, challenging the base of support beyond the base of support. That is challenging your line of gravity to reach to the margins of base of support or beyond the base of support. Axial rotation of the trunk, because truncal rigidity is also a very big aspect which is interfering in the patient with Parkinson's disease. Stepping, marching, reaching, one leg standing, side walking, cross walking, step up, step down with the same leg, alternate leg, zigzag walking, reverse walking. Lot of different exercises or ideas can be used for balance training of a patient. Locomotor training, where there is a primary focus on the gait impairments, slowness in the walking, shuffling gait pattern, diminished arm swing, trunk movements. So training programs can incorporate each and every dimensions like broadening the stride length, broadening the base of support, improving the stepping, improving heel to toe pattern, increasing the contralateral arm swing, increasing the speed. You can use sticks in the hands of the patient with the sticks hand other hand by the therapist, facilitating the arm swing of the patient, correcting the posture of the patient, giving feedback in front of the mirror to the patient, increasing the base of support, challenging the base, using different surfaces for balance and locomotor training, practicing in a normal surface, practicing on a foam surface, practicing on a slippery surface, Whenever the surface changes, it gives a best feedback, a best proprioceptive feedback to the patient, and it also helps in improving the balance of that particular patient. Gait training can be done also by using the overhead harness, like whenever treadmill training or any type of mobility training are done, can be done with the harnesses, verbal cues, reciprocal arm swing, and changing the direction, crossing the obstacles. You can highlight the obstacles with different color coding or different positioning, which can give a visual feedback along with the crossing of the obstacles. So this type of small and multiple modification can be made in the management of that particular patient. Cardiopulmonary training, like depending on the cardiopulmonary assessment of my patient, that if there is any requirement of diaphragmatic breathing, deep breathing exercises, improving the thoracic mobility, aerobic training to improve the endurance, or addressing the aerobic and strength training has always helped to improve the physical ability of the patient. Apart from this, the most important thing is always to address the cognitive and emotional aspect of that patient. Always, as a healthcare professional, it is a duty to deal with the cognitive, emotional apathy and the psyche of the patient. The patient has lot of emotional factors which comes because of the limitations in day-to-day life or limitations in the activity performance. The patient may have so many emotional and cognitive factors which are affecting. Maybe the memory of the patient gets affected, or the expression of the speech also gets affected, or the social limitation because of the change in facial expressions or micrographia may be a very impactful, because every individual is different and there is an important need for a patient. Maybe some person is bothered about micrographia most important rather than other things, or some patient is more concerned about the drooling of saliva, or some patient is more concerned about the lack of expression on the face. So it all depends on each and every patient. So it's our duty, or it's the most important part, to address the cognitive aspect of the patient and give the emotional support to each and every patient who is being seen by a healthcare professional. Always liaise with the patient as much as you can and find out the need of what other healthcare professional is needed by my patient, and specific referrals can be always made and initiated in a particular time. Exercise prescription. We know how to assess our patient, how to give the exercise, what exercise to be given, but one more important part in prescribing the exercises is creative treatment and early intervention. Similar to drug prescription, exercise prescription needs to be very careful, and a consideration should be given to the symptom presentation of patient, need of the patient, individual goals. As I mentioned, that each patient has a different set of priority. So what is your patient concern or priority? According to that, you need to make a tailored protocol. Owing to the diversity of the symptoms, one exercise will not be effective for each and every patient. So synopsis from the literature suggests that exercise should address the components of strength, balance, flexibility, endurance, amplitude, functionality, and the cognition. FIT principle can also be used to guide the prescription of the exercises for a patient with Parkinson's disease. If we look to the global approach in Parkinson's management, or the globally approached published approaches, there are three most popular Parkinson-specific internationally recognized exercise programs. They are nothing different than what we discussed till now. Each of the approach is highlighting some aspects more and some aspects less, and they are the perks and up combinations of the previous approaches or the previous treatment strategies that we have discussed. But these are the three internationally recognized, literaturely published, and the most relevant approaches that are used in current date for management of physiotherapy in patients with Parkinson's disease. That is PD Warrior protocol, which was developed in Australia, and it is supported with a PD Warrior app in which an application is supporting a patient with Parkinson's disease. Parkinson's Wellness Recovery, that is PWR, an American program, and LSVT, which is a England-based program or a UK-based protocol, which is delivered in a 1:1 way for 5 days a week. So these are some of the internationally recognized. This is just to add up or sensitize you with some things like that. There is something like this which is going on in an international fraternity. These are some things which you can always go through whenever you want to devise a detailed protocol for your patient. Thank you so much for all your patience and hearing me. These are some of the important references which can help you to give a lot of details about the aspects that we have discussed.
Thank you so much, ma'am.
Thank you. Shall I stop sharing my screen or do you need?
Ma'am, you can stop sharing it. Ma'am, that was quite an informative session and elaborating too. Now we'll welcome some questions from the audience, ma'am.
Yes,
Shall
yes,
we?
please. Yeah, sure.
Anyone from the audience who have any queries related to the topic?
Ma'am?
Ma'am, how these modern intervention is beneficial in case of Parkinson's?
This are not a modern intervention. These are the interventions which have been devised using the combinations of the treatment strategies that we have seen. Each and every intervention is just having a different frequency or different pattern. Like some of the approaches are using 1:1 protocol, whereas some are taking a 24-hour constant monitoring of the patient by a mobile application or a IT gadget, which is constantly monitoring. So just it's a way of delivering that approach. There is nothing different in the treatment strategies which are being used in the approach.
Okay, ma'am. Thank you.
Thank you.
Any other question? Ma'am, there's one question.
Yes, please.
Ma'am, how quickly this disease usually progresses, Parkinson?
Good question. Excellent question. It depends on multiple factors that how quickly a disease with Parkinson's progresses. There is no literature or a specific guideline which says that this is a particular speed of progression of the condition. It depends on the genetic factors. It depends on the hereditary factors. It depends on the lot of the physical factors which a person is having in the life, the emotional state or the cognitive aspect of a patient, and the most important, how quickly the neurodegeneration is taking place within the extrapyramidal system. So there are many factors which can affect the rate of progression. That's why it is always instigated that the early onset of the treatment or early onset of therapy always halts the progression. It can never stop the progression because it's a neurodegenerative disease. It is a degenerative progressive disease. So there are the multiple factors which affect. And if any of these factors are progressing or affecting a person's life to a greater extent, maybe it can increase the deterioration. Or however, if all these factors are kept balanced in a particular life, maybe the rate of progression slows down. I hope that is clear.
Yes, ma'am, it's clear. Thank you so much, ma'am. Ma'am, there's one more question.
Yes, please.
In your exercise prescription, there is one thing. What do you mean by creative treatment?
Creative treatment means to say is that we have to use creative ideas. For example, we know that we need to use the shoulder flexion as a treatment if there is a restricted range of motion in the shoulder flexion. Can you hear me?
Yes, ma'am, Master, you're audible.
Yeah. So I'm trying to say creativity needs to be in each and every therapist individual program. Like there is a restriction of range of motion of shoulder flexion. So the only solution to overcome that is providing the shoulder flexion. But how you can provide the shoulder flexion is your creativity. Maybe you are asking the person to reach a thing placed on overhead shelf. That is your creativity. Or maybe you are asking an individual to place the basketball into the basket. That is your creativity. Or maybe you are asking the person to take out some clothes placed on an overhead shelf, or putting something or picking up something from the floor and keeping it upstairs. So this is a different type of the things which you can use as your own creativity to target that. So your target is to achieve the shoulder flexion, and what strategy you are using for that, that is your creativity in designing that particular exercise. I hope that's clear.
Yes, ma'am. Thank you so much, ma'am, for clearing our doubts.
Yes, anything else?
No, ma'am, thank you so much. On behalf of BCIP, I would like to thank you for sharing your valuable knowledge with us. That was such an exemplary session. I would like to thank our viewers for being with us.
Thank you so much. I would like to thank each and everyone participating in the session, each and everyone listening to me patiently, and again, BCIP, the staff of BCIP, the management committee of BCIP, and each and everyone who is responsible for organizing, chairing, and sharing such a big platform for me. Thank you so much.
Thank you so much, ma'am. Keep following BCIP. Thank you all the viewers. And this is for the viewers and participants. The feedback link is in the chat box. You can fill it there. Okay, ma'am. Thank you so much, ma'am.
Thank you so much. Have a great day.
You too, ma'am.